I think that was my cue. Um, Welcome, everybody. I'm really excited to present our Grand Round speaker today. I'm Tashani Alangasekar. I'm the director of our OB/GYN Grand Round series. Thanks everyone for joining today via Zoom. As we do, I'm going to start with our land acknowledgement. So we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And as residents of the Bay Area, we can deepen our commitment to this process by contributing financially in the spirit of reparations and land rematriation. And you can look here for some links and in the chat on how to contribute and learn more about the Ramaytush Ohlone people. And so I am very excited to present our speaker today. We are joined by Stephanie Cizek, who is a clinical associate professor of pediatric and adolescent gynecology at Stanford University and the fellowship director for Stanford's Fellowship for Pediatric and Adolescent Gynecology. Her clinical leadership roles include medical co-director of the Stanford Differences of Sex Development, co-founder of the Stanford Children's Complex Colorectal Urology Gynecology Clinic, and pediatric fertility preservation lead. She is North American Society for Pediatric and Adolescent Gynecology Research Network Chair, and the immediate past chair of the AAGL PAG SIG and is on the JPAG editorial board. Lots of acronyms this morning. So I'm really excited to present, to hear about her work in ovarian fertility preservation throughout the lifetime. And we send you a warm welcome. I'm going to pass the mic over to you, Stephanie.
Thank you so much for that lovely introduction. And hi, everyone. Good morning. Thanks for listening in. I'm a pediatric and adolescent gynecologist, and I have been invited to talk today on a topic that I really love to discuss, which is fertility preservation. This lecture should really just be called Cool Things in Fertility Preservation, because honestly, that's what I want to share with you today. The excitement that I have about the things that are happening in this field. There's so much going on. Importantly, I am not an REI. You guys have a fabulous REI department. Dr. Rose and I have seen at multiple advocacy meetings that for fertility preservation access to care. I think it's important, though, that we all recognize our roles that we each can play in providing fertility preservation care for our patients. So from people like me, pediatric and adolescent gynecology, to REI, to generalists and MIGs and gyn-onc, we all have an expertise that we can bring to this area, and our patients can better get the care that they need when they still have fertility to preserve, and then to be able to use what they have preserved when they're ready to have a family. I have no interest to disclose. One day, maybe I'll have interest. So the brief run through is there's 4 objectives. So I want to talk about why fertility preservation is important and when to talk about it, what methods are out there for fertility preservation, and then what happens after we collect the tissue for fertility preservation, and what are some barriers. So this first objective I want to start with is just to talk about how this field has exploded in the last few decades. And the part of the reason for that is just patient demand. There is now at least an 85% 5-year survival rate for patients with childhood and adolescent cancers. And these cancer survivors are now living long enough to experience the fertility repercussions of their treatment. And we call it fertility preservation because the goal is to intervene to preserve the fertility before the exposure of the gonads to the toxic treatment. And this is, of course, when we're talking about ovaries, because they're born with all of the follicles that they're ever going to have They never create more follicles, and we don't right now have any technology to repair damage to the primordial follicle pool, so the toxic effects of treatment are irreversible. And this affects many people. So when we're talking about childhood cancer survivors, over 6% will get diagnosed with primary ovarian insufficiency within 5 years after treatment, and up to 10% will have POI sometime before the age of 40. And these numbers, of course, don't take into account people who are out there and who are undiagnosed, or people who might have suboptimal fertility but not a diagnosis of POI. And people who have POI not only have infertility, but they need treatment with hormone therapy until the age of typical menopause, which is on average around age 51. So initially this field was focused on just oncofertility, and we've moved away from that to calling it fertility preservation because it's actually not just for people with cancer. This is an incomplete list of conditions in which patients whose condition or whose treatment might affect their fertility and who might benefit from fertility preservation. So in the first column, a lot of these anemias are now being treated with stem cell transplants, and stem cell transplant is highly toxic to the ovaries. In the middle column, lupus is a great example of a condition that is often treated with cyclophosphamide, which is a notoriously gonadotoxic treatment. And my very youngest patient, who I did fertility preservation on, was 4 months old and who had HLH, which is a severe immune system disease, and that falls into this category. And here's how we figure out who's a candidate for fertility preservation. So these risk calculator charts were published in 2020. It turns out 2020 was not a great year to publish things that you wanted to be widely disseminated or picked up. There's a lot of other things going on, but this effort was led by Lillian Meacham out of Emory. And these risk assessments are based on imperfect data and knowledge about the toxicity of different treatments, but they do help to estimate what risk sort of bucket that patients might fall into before they get their treatment. And they divide this into minimally increased risk, significantly increased risk, and high level of significantly increased risk. Risk categories that I think we can all agree are maybe the names in this next iteration. I'm a part of a project that is working on revising some of this, and probably this is going to change a little bit with the next iteration. But on this risk calculator chart, a couple things to point out. So one, you can see that pretty much everybody who gets a hematopoietic stem cell transplant, it falls into this highest risk category for developing primary ovarian insufficiency. Another thing to point out is that age for people with ovaries is a protective factor, but this can also lead to a tendency to downplay risk in prepubertal girls. The higher doses of the same chemo are needed for infertility to occur, but absolutely these kids can reach this highest risk categories as well. And then radiation to the ovaries, and also it's not on here, but radiation to the uterus can affect fertility. And then radiation doesn't have to be just to the pelvis. Cranial radiation can damage the hypothalamus or pituitary, which can stop hormone pathways to the ovaries. I'm going to give only a little bit of time. I just wanted to testicular fertility preservation, but I just want to point out that there is an equivalent risk assessment chart for testicles. So I'm a gynecologist, I can't even say the word. It took, I think one thing to note is that testicles are much more sensitive from a fertility aspect. It takes, for example, at least 10 gray to cause POI in an ovary, but just 4 gray of radiation can cause infertility in a testicle. And then also note that testicular fertility toxicity is not different by age of exposure. So there's no protective effect for young males. You'll notice on these charts, I just wanted to point out this like CED. So for alkylator, which is a type of chemotherapy, this is cyclophosphamide equivalent dose. And so there are calculators online. This is one I use from Pittsburgh. And so these calculators help to estimate the toxicity of chemotherapy. It's based on assigning cyclophosphamide an equivalent dose of 1, and then you can put in other chemotherapies which have different multipliers based on what we know about their toxicity, again, to estimate someone's risk of infertility. So POI is a devastating diagnosis. and one that unfortunately many of us see all too frequently. Patients describe this as a whiplash type of feeling. They thought they were done, and now their cancer or their other disease is again taking something more away from them. And some of these patients were children during their gonadotoxic treatments and have variable knowledge and expectations regarding their future fertility. And these can be really, really hard visits. Even for people who knew that there was a risk of infertility from their treatment, it's still really painful to hear it confirmed. So this is really just good patient-centered care. Patients say this is really important to them. I think one really interesting thing is that people who had fertility counseling, even if they chose, or even if their parents chose not to pursue fertility preservation, report later lower rates of regret and dissatisfaction, and improvement of their psychologic outcomes. And I think this can be really reassuring to parents who are really struggling sometimes to make this decision for their kids who might be young. And I kind of counsel them, hey, there's actually information that says just us having this conversation and documenting that we spent some time discussing this really helps your child in the future. Even adolescents have been shown to desire information on fertility risks and their options. They really want to participate in decisions, but like a lot of things related to gynecologic health, they're hesitant to bring up this topic on their own. So this has all come together to lead to fertility preservation being now considered standard of care by most major medical organizations. And even though every society's statement on this is a little bit different, they generally have the same guidelines, which is that fertility discussions should happen before the treatment occurs that is toxic to the gonads, that there should be a referral to a person who can specialize in talking about fertility preservation for any person who is interested in having that referral, and all available fertility preservation options should be offered. So then what are the options? Again, I'm giving short shrift to the testicles, and I'm sorry for that, but this is just one quick slide that I want to highlight some key points. So whereas for ovarian fertility or ovarian failure means both hormone production and fertility has been affected, males are actually less likely to have the hormonal failure part. They can often continue to produce testosterone and go through puberty, but just not producing sperm. So the goal of fertility preservation for males is really focused on just preserving fertility, whereas there could potentially be a hormone component for ovaries, which we'll get into later. Sperm can be collected by masturbation most easily, or sperm extraction for people who are unable to produce a sample. Testicular tissue cryopreservation is actually the only option available to prepubertal patients and is still considered completely experimental. Okay, so for ovaries, I put Depo-Lupron on here just as a note because it's often thought of as a fertility preservation agent. But I'm a pediatric and adolescent gynecologist, so I think about for kids, there's actually not clear data to show that this improves fertility outcomes for children. The best data to support Depo-Lupron actually comes specifically from adults who are treated for breast cancer, and some data also for people with lupus. And it's actually, in pediatrics, we usually use it for menstrual suppression, but I would not consider it a primary method of fertility preservation. For people getting radiation, there's a few methods that can be used to protect the ovaries. So ovarian shielding is just trying to cover up with lead during the radiation therapy, the area where the gonads are. And then ovarian and uterine transposition, I want to spend a second talking about because I think this is kind of cool. So these are moving these organs actually out of the field of radiation. And this is a video that we made. So this is in a little 6-year-old. You can see this little teeny prepubertal uterus. And so this was a ovarian transposition surgery that we did for a patient who had rhabdomyosarcoma. And so this is the little prepubertal ovary on the left side. You can see much smaller, smoother, a little bit more yellowish in color than an adult ovary. There's not like the bumpy surface that's showing the development of follicles there. And then here we're ligating the uterovarian ligament so that we can flip the ovary up and out of the pelvis. And here we're just loosening up the IP ligament so that we could pull it out of the pelvis a little bit more. And the goal was, so this was per our radiation oncologist, so we backfilled the bladder because they wanted us to stay at least 3 centimeters above the bladder. That was their planned field of radiation. And so we marked that on the abdomen, and then we used that to find the corresponding spot of where we needed to pin the ovary to during the surgery. And we used the method of creating a peritoneal window, which is thought to be a little bit more likely to not fail, so that the ovary is more likely to stay in place where you sutured it. So we create this window through the peritoneum, and then we're going to thread the ovary right through it. And then we're going to suture it in place. And the lovely thing about edited videos is our suturing looks just so quick. Look, one knot already done, a second, and then a third, and then we put staples into the knots and one right here just so that it can be detected on imaging where the ovary is. And then this is the other side. We're doing the same thing on both sides. And the same thing, multiple sutures and some staples. And then I wanted to show, in case you're wondering, this is what oh, that's the pelvis with the ovaries not in it anymore. So this is vaginoscopy. This kid had rhabdo of the distal vagina and behind the bladder as well. And so that was a little baby cervix, but this is, I think, a nice classic example of what rhabdomyosarcoma looks like. We always talk about those grape-like clusters, and this was what was in the distal part of the vagina. If that is already fun, so this is happening too. So I think we're focused on ovaries in this talk, but radiation can also cause uterine infertility. And this is just such a cool thing that I wanted to share with you, that this surgery is happening. Actually at Stanford, we're doing our first one next month. That this is, and this paper in Fertility and Sterility has a great video on showing uterine transposition. But basically what happens is you cut the gonadal vessels and you flip the uterus up so that the cervix is at the umbilicus, and then the patient actually menstruates through the umbilicus, which is just so wild to me. And I think this is like a really cool technology. Obviously, very select patients would be candidates for this. So then there are other methods that involve freezing of tissue, and that's embryo cryopreservation, oocyte cryopreservation, and ovarian tissue cryopreservation. Embryo cryopreservation in my world is not very common because you need a known sperm donor for that, and my young patients typically don't have that. And so we're going to focus really on oocyte and ovarian tissue cryopreservation. So oocyte cryopreservation is available to females who have undergone puberty. Random start protocols mean you can start this process immediately, and it takes about 2 weeks with about a 6.5 variable, of course, by place and by patient, chance of live birth for each frozen and thawed egg for young patients. Usually you want about 15 to 20 eggs for people who are less than 35 years old for every child that they desire. But this is, for people who are young, even if they are post-pubertal, this is a daunting process. You're talking about 2 weeks of hormone injections, closely monitored with ultrasound. Transvaginal ultrasound is strongly preferred, and then an egg retrieval process. And even though you can try to modify this process for young people, it is still really daunting, really challenging. But for anyone who can do it, this is still the best, most well-studied, most established option for people who want fertility preservation, who have ovaries. And so all efforts are made to try to use this whenever possible. But when not possible, ovarian tissue cryopreservation is the other option. So this is for prepubertal patients, or for people who don't have the 2 weeks or that is needed to get the oocyte cryopreservation, or again, for people who might be old enough to get it, but just the process itself is too overwhelming or daunting for them. There are no age limits on doing ovarian tissue cryopreservation. Again, the youngest person I have personally performed this procedure on was 4 months old. This is done via laparoscopic surgery. Generally, for prepubertal patients, we remove a whole ovary. For older people, sometimes we do a partial ovarectomy. Chemotherapy can be started the same day, although my preference as a surgeon, and I know the oncology team preference, is usually to allow more recovery if you have the luxury of time. Complication rates are very low in most studies, and every patient referred for ovarian tissue cryopreservation at our institution is reviewed by our team, and we ensure that there's no medical or baseline fertility reasons that this should not be performed. Just to give you an idea of what this looks like, so this is from some still shots from an animation that I made when I was a fellow. It's laparoscopic surgery, and for prepubertal patients, we usually take the whole ovary, but partial ovarectomy would mean removing part of the cortex of one of the ovaries. Then the ovary is sent to the cryopreservation labs, where it's essentially sliced open like an orange, and the surface, which is the cortex, is like the rind, which has all the follicles, and this part is then cut into pieces and frozen down. And the way this tissue is used for fertility is that later a second laparoscopic surgery is performed, and a few of these strips are placed back into the patient's body. A common spot to put it back on is to sew it back onto the remaining ovary. This is an example of ovarian tissue cryopreservation, also in a prepubertal patient. So again, this little tiny baby uterus, you can barely distinguish it from the surrounding round ligaments. And then here's the fallopian tubes in yellow, the bladder, and the colon. So we're using here a 3 millimeter cool seal, which is used to, I'm sorry if I know there's like background audio on this, but the cool seal actually has a 1 millimeter thermal spread, and you're really trying to minimize any burning of the ovarian tissue. There are people who are using cold techniques to dissect these ovaries, and it's actually something that we have started to look at if whether or not we should be doing that, because there is some data from pig studies that if you're even within 2 centimeters of the ovary, there might still be some thermal burn. But again, that was using instruments that were not so tiny, like this little cool seal that we're using. And so then the ovary is placed into a bag, and then it's removed and sent to our cryo lab. This is showing the shared blood supply for the ovary and the fallopian tube. So when you remove the ovary, you can actually impact the fallopian tube, and you do need to inspect it to make sure that you haven't devitalized the fallopian tube. So ovarian tissue cryopreservation was considered experimental until 2019. And then the experimental label was removed, because at this point now we have hundreds of live births around the world that have been done using auto-transplanted ovarian tissue. The exact live birth rate is unclear because we don't really have a great denominator, but it's estimated to be somewhere in the high 20s to low 40s%. Even though this is no longer experimental, there's a lot of unanswered questions for specific populations. For example, prepubertal patients have immature ovarian tissue, and to mature this tissue, it's going to rely on in vitro maturation. And in vitro maturation is a technique that is still in development. Another big concern is the risk of auto-transplanting tissue for people with cancers that might have hematologic spread. There actually are reports of people with hematologic malignancies having auto-transplanted tissue without relapse of their disease, but it's still not currently recommended to do that, and it's unclear, do these people have to be in remission before the tissue is frozen? Does that make a difference for what their risk is later? So I think there's a lot of information that we still need on that. So now I want to just go through a lot of the questions that come up about, okay, we have the tissue, we've we've chosen a method, and what happens then after you do the fertility preservation? So one question is, when can we start the treatment? And I think I mentioned before, we can start as early as post-op day 0. Nobody loves starting on post-op day 0. Definitely the oncology teams don't love doing that. And of course, as a surgeon, I would prefer that we don't start chemotherapy on a patient that I just operated on. But we did do a study out of our own institution, and we found that only 2 of our patients experienced a treatment delay. Both of these, unfortunately, were my patients. One of them had methemoglobinemia, which is an extremely rare anesthesia complication. So not actually from the surgery itself, and very hard to predict that one. The other one was delayed due to severe post-op abdominal pain, which we suspected and ultimately were proven to be correct that it was related to severe constipation, but kind of illustrates how tough it is. You have these sick kids, and it's hard to distinguish post-op bumps in the road with constipation from more severe complications. And the transplant team decided for that patient, because we were not completely sure right away, to delay the therapy. But overall, there was the median time to starting therapy was actually just a day and a half. I think it's really interesting to consider, we do all this stuff to promote fertility preservation, and who is using this tissue? And so far, not huge numbers of people. So this chart breaks down how many people return to use their frozen stored oocytes or embryos or semen or ovarian tissue. And particularly the ovarian tissue rates of return are very low. And there's a lot of reasons for the low return rates overall for all of these categories. So one is obviously we might just not be capturing all the people. They might move somewhere, they might have their tissue shipped somewhere, they might be going through private institutions for their fertility. So there's a lot of things that we might just be missing people. There's also the thought, though, that a lot of people who are getting fertility preservation tend to be the people who are getting the most gonadotoxic treatment. So potentially they might also be the people who have the worst prognoses. So even though we mentioned earlier that 85% of people with childhood cancers now survive past 5 years, the people who are actually getting the fertility preservation might have more aggressive disease. And one 2019 study showed a 13% mortality rate among people who had frozen their ovarian tissue. People freezing tissue as adolescents and adults are actually more likely to use the tissue than people who were younger at the time of freezing it. But that also includes the caveat that younger people just might not have aged into wanting to use their tissue yet. Some people don't return to use their ovarian tissue because they ended up doing both procedures. So if they needed to right before treatment, or if it was the only option, did ovarian tissue cryopreservation. And then if they had some ovarian function after their treatment, some people will choose to also undergo oocyte cryopreservation, again, knowing that's the better, more established option. And then they only use the oocytes and not the ovarian tissue. Young cancer survivors, for a whole host of reasons, mostly related to sexual health and mental health, are less likely to have married relationships, which could be a factor in deciding to use their tissue. And some studies have suggested that maybe this population is also less likely to decide to have children in the future. And then studies that have looked at why people choose to end paying for their annual storage fees for their tissue find that, one, it's a high cost just to pay for the storage fees for this tissue. And these are people who have had lots of medical treatment if they underwent fertility preservation. And the idea of having more medical procedures is really, I think, a deterrent for a lot of people. So then for people who did ovarian tissue cryopreservation, who do want to use the tissue, where do we put the tissue when it's transplanted back in the body? And the answer is all over the place. So we just divide into orthotopic, which means in the pelvis, and heterotopic, which means anywhere outside the pelvis. Orthotopic is the most common, but this does require another laparoscopic surgery. And for some people, for example, post-pelvic radiation, there might not be healthy tissue in the pelvis to transplant the ovary back onto. Heterotopic locations look for fatty or muscular tissue, usually in the subcutaneous tissue of the abdomen or even in the forearm. So this one heterotopic site was published in this case report from Dr. Octay in 2001, and you can see this bump here is where the ovarian tissue is in the fatty tissue of the forearm, and they used ultrasound to demonstrate that there was follicles developing under the skin from this ovarian tissue. And then here's an example of tissue being transplanted. This is in the pelvic sidewall, so in a peritoneal pocket. So this is the uterus here, and then you can see these little strips of ovarian cortex that were thawed and placed into this peritoneal pocket, which was then steepled shut. So many patients ask me if we're taking this out, can we put it right back in right when we're done with the treatment? Because then I don't have to use hormone therapy. I can just, Melissa, why are we waiting to replace the tissue? But the problem with that is the tissue only lasts about 2 to 5 years in the body. There are people looking at scaffolds to try to help extend the lifespan of this. That's a future direction for this. But in general, that's part of the reason that only a few strips are placed at a time back into the body, is that the function of them only lasts for a limited time. Another question that comes up is, can we make things worse? So one of those ethical questions of first, do no harm. So there's two parts to this answer, and the first part is that just to consider the freeze-thaw process and the impact of the tissue on that. So right now, this number varies by study, but some people report up to 75% of the follicles might be lost just in the freeze-thaw process. In the future, we might have other ways of using the frozen tissue. Allotransplantation into someone else's body or in vitro maturation could end up being even better. But right now, those are experimental. And so this is one reason why for ovarian tissue cryopreservation, we generally only perform this procedure for people who are at the highest risk level of gonadotoxic therapy, which is different, of course, right, from oocyte cryopreservation. That is done all the time by REI for people who aren't even undergoing gonadotoxic therapy. Definitely for both of these, there are risks and benefits to weigh. For example, a severely neutropenic person might not be a candidate for either OTC or oocyte cryo from a medical standpoint, but from a risk standpoint, this follicle loss in the freeze-thaw process really makes OTC and the surgical risks associated with it. You got to really kind of balance that when in the discussions with patients. The second answer to this question is thinking about the function of the remaining ovary. So there's multiple studies looking at the effect of removing one ovary and how it affects fertility in the age of menopause. And we know that in general, it can make the onset of menopause at least a little earlier, and that for people getting oocyte retrieval, a single ovary is definitely can lead to increased use of need for more gonadotropins and a lower number of follicles or oocytes retrieved. I have to, for PedsGyn, say something that I have to say way too often in my field, which is that a lot of this data is not focused on the youngest patients, and the youngest people in many of these studies were actually around like in their late 30s or early 40s. And so for people who were talking about removing an ovary in childhood, there's not good long-term data on outcomes for people where we removed one ovary. Really interesting to me as a PAG provider, but also I'll show you that this connects as well to adults. So where are we in the technology for using this tissue that we've frozen and then we can put back into the body for hormone production? So there's actually two case reports on pediatric patients. One was on a 10-year-old who was Tanner 1 breast development at the time of OTC. They had sickle cell anemia and they were planning a stem cell transplant. Then they, at 13, underwent a heterotopic transfer. They put it in the abdominal wall above the mons pubis. And this patient had thelarchy start 2 months after the tissue was transferred, and menarche at 8 months later. They had regular menses for 2 years, and then it went, and the menses became irregular and eventually stopped. This second case report is of a 9-year-old with Ewing sarcoma in the pelvis who had OTC, and then had an orthotopic ovarian tissue transplant at age 13 and a half. And they had menarche start a year after the tissue transfer, and they had regular menses for 6 months, and then the graft stopped functioning. So does this mean that we can use auto-transplanted tissue for menopausal hormone therapy? There are definitely pros and cons to thinking about the use of tissue this way. Some big pros are that this is the most physiologic of hormone replacement. And the tissue would actually have fertility potential, which is an advantage that also has some, might be a little ethically messy there. The disadvantages, of course, are a long list. So I love thinking about this concept of tissue hormone therapy. We're not really at the point of making this a routinely great option, and I think this summarizes it well, which is that cryopreservation and transplantation of ovarian tissue exclusively to postponed menopause is technically possible, but endocrinologically doubtful. So I think we're a little bit of a ways from using this tissue in that way. Some things that come up, and this is, I think, not uncommon, that we sort of have these like ethical conundrums that come up with the use of fertility preservation, and particularly for my younger patients. So should we be using this at all for people who have only a low risk of infertility? Again, I think there's, as we mentioned before, different potentially risk benefits to weigh for people using OTC versus egg freezing. What about people who have a poor prognosis? I think this leads right away to some gatekeeping sometimes from the primary treatment team of whether or not to even refer somebody for fertility preservation if they have a really poor prognosis. I think this is tough, right? But there's also, this is a very like future thinking conversation for a lot of people. It can bring a lot of hope about what life might be like after treatment, but also in the setting of somebody has a poor prognosis, we're talking about costs and risks. And but again, I think there's a paternalistic aspect to maybe not offering it at all, that can be kind of ethically complicated. There's a whole like list of people who are not necessarily easy candidates for this. And so some ethical principles that we have to keep in mind are, obviously first, do no harm. For younger people, the right to an open future, which is preserving as many future choices for their fertility as possible. Thinking about, parental like care and autonomy and making decisions for their children, but also like prioritizing autonomy of the patient. This comes into play a lot for patients who are candidates for egg freezing, but who might, as teenagers, not really want to be undergoing that process of egg freezing, but might be kind of being egged on or pushed a little bit by parents, and making sure that you talk confidentially to patients. And are they the driver of this decision? And what is in the best interests of the child? Trying to keep that first and foremost. So in vitro maturation, we mentioned, is in development. And I think this is, when we're talking about fertility preservation, a big point to keep in mind, that we really have very little data about people who were really young, prepubertal, who later had live births. And to my knowledge, there are only 5 reported, and 4 and 5 were reported in separate places, but you can see their characteristics are very similar, and they're probably the same patient. But all of these patients, none of them were like 2 or 3 years old, right? All of them were 9 or above, So the ones who had puberty status completely, like specifically mentioned, 2 were completely prepubertal. 1 was noted to already have some thelarchy. But at 9, these ovaries might not be completely quiescent like they are in a prepubertal kid. There might be already some HPO axis activation happening. So I think there's a lot of unknowns here for tissue freezing for really young patients. And then, of course, one important part of fertility preservation is monitoring somebody after the treatment. This is the chart that we use at our institution for trying to track people afterwards, monitoring for if they were prepubertal signs of puberty, or and making sure that we help them through puberty induction if they do not have functional gonads, and then post-pubertal monitoring for POI. Because of course, when we do this fertility preservation, not 100% of people will have no function of the gonads after they're done with the treatment. And in fact, this is also a really good opportunity for people who still have some function, who didn't do fertility preservation, to maybe take advantage of a window of opportunity here where the ovaries are still working, to have like egg freezing or something done. So then talking about barriers, there's a lot of barriers to fertility preservation at many different levels. So in some cases, it's just a lack of provider knowledge of gonadotoxic effects or fertility preservation methods, lack of specialists, or lack of easy access or efficient consult systems to see a specialist in time before the gonadotoxic treatment is administered. However, even providers who have the knowledge and resources report in studies that they might still avoid the topic, citing prioritization of the oncology diagnosis and treatment, or discomfort in having these discussions with patients. From a patient standpoint, these are, again, sometimes some pretty sick patients, and there can be some real medical reasons that a procedure might not be safe. Emotionally, it's also an extremely overwhelming time for patients and their families to be weighing fertility preservation options on top of everything they're already going through. There's also, of course, the ethical considerations to take into account, and assumptions that are sometimes made about patients and what they value or prioritize, or whether they are able to pay for the treatment. And I want to talk about cost, so I'm going to skip ahead a little bit. Let's skip that one. So oocytes, or ovarian tissue, or ovarian fertility preservation, the procedure itself is obviously like very expensive part of the process, either egg freezing or ovarian tissue cryopreservation. Then add to that, there's the cost of freezing the tissue itself, and the cost of keeping it frozen annually. This is the cost, unfortunately, at Stanford. Now we have ways of trying to bring down these costs for patients, but then this also doesn't take account into the future costs of using this tissue either for IVF or the ovarian tissue transplantation, which has its own very high costs. You might all be aware of some changes in fertility preservation laws in California. In 2019, California passed Senate Bill 600, which requires insurers to cover fertility preservation treatment for any person who's undergoing gonadotoxic therapy. At conferences I've attended, people talk about how this makes California a model to other states, and yet our reality is very different. Procedures are still mostly denied under this law, and many insurance plans in California are self-funded, which means they're not governed by they're governed by federal law and not state law, and therefore not included in this. Religious employers are exempt if IVF is not a part of their religious beliefs, and people on public insurance, Medi-Cal and Medicaid, are not covered. And if there's a denial of fertility preservation, and even if you think you can appeal it, the appeals process for insurance is lengthy and often means that you're now out of the window of being able to do fertility preservation. And then this is Senate Bill 729, which I don't know if you're aware, because this is very recent. It was actually passed in 2024, but not enacted until January 1st of this year. This actually is a big deal. So this is in California. This is people call this the IVF mandate, but broadly it includes it covers the diagnosis and treatment of infertility. And they define infertility as the inability to reproduce either as an individual or with their partner without medical intervention. So this is now expanding the definition to include LGBTQ plus people and single people who cannot build a family without medical intervention. However, there's still, one other thing under this law, which I'm amazed at, is that they include coverage for the cost of ovarian tissue transplantation, which is, oof, don't know how that got through. But the same loopholes still exist for private insurers, and it still does not cover Medi-Cal patients. Um, there are some things, and I'd be curious if there's, what your institution does, but there are some steps that we do try to take to mitigate the costs for fertility preservation for our patients. So for our children's hospital, we will cover the ovarian tissue cryopreservation surgery as long as this person is getting their oncologic treatment or their stem cell transplant at Stanford. And as long as we couple it with another OR procedure like their central line placement, which sometimes means we're doing some gymnastics to try to get this all covered and arranged together. We have a 50% discount for people who are getting gonadotoxic therapy on the cryopreservation and storage fees. And we have tried to reduce our annual storage fees by contracting with ReproTech. So people who are storing for the long term, we send to them because their storage fees, if we include the assistance programs that often patients qualify for, can be as low as like just over $100. Um, so I'm really proud of our fertility preservation team. It's been a lot of work, and the backbone of the program are the nurses and the fellows and the OR teams and the auth department that you really have to get involved in this program building and get on board with everything, because they're the people that help make things happen urgently when things need to be done. But we have like all of these specialties involved in the program. And I think we've built something really cool. And this is our, in case you weren't aware, our North American Peds-Gyn Society, NASPAG, is having its annual conference in San Francisco this year, and we are actually combining it with the World Congress of Peds-Gyn. So it's going to be a very big conference in April. And if you have anyone trainees or faculty who are interested in learning more about pediatric adolescent gynecology, I encourage you to attend this conference. All right, I'm done. I don't know if I went way over.
You did it. You did great. We have
Thank you.
a couple minutes left. Thank you so much, Stephanie. This was excellent and so fascinating, some of the work that you're doing and some of the technology that is out there and that you presented. If anyone has any questions, please go ahead and unmute and ask. But there was some interest in the and shock and awe when you talked about the uterine transplant surgery. And so there was a question by Nagma Faruqi who asked, do you reverse the cervix back from the umbilicus back to the vagina and at what age?
You do, and so in general, again, this is very experimental, so there's no like protocol of what is done here, but they've reversed it when somebody is done with their treatment, because otherwise this person is now menstruating through their umbilicus sort of indefinitely, and you do have to think about like cervical cancer screening even through the umbilicus, and so they generally have been rotating the uterus back down and anastomosing it back to the vagina after the person is done with treatment.
Seeing if there's another question before I ask my question.
Okay.
Um, it sounds like it takes a lot of coordination between labs and people and surgeons. How do you counsel patients when you're seeing them? Like, how does this, in terms of whether they're going to be a candidate or not? You said that there's like some criteria that you're using. How do you decide when there's so many people who are involved in the decision making, and how do you kind of guide your patients through that?
Yeah, that's a really great question. And so that has involved a lot of outreach and education to the programs that are sort of our primary referral programs. For example, for people, the stem cell transplant team, because pretty much everybody who gets a stem cell transplant falls into that highest risk category. We have done a lot of outreach with our stem cell transplant team and incorporated Epic alerts into the treatment planning for the transplant team, where they have to actually click whether somebody has had fertility preservation consultation or not. And the those risk calculators, I think, are really important because I don't know, like, there's no way for us from the fertility teams to monitor like everybody in the hospital and try to identify everybody who is getting potentially gonadotrophic treatment. So we really rely on people to identify within their own patient population who is in a higher risk category and to talk about fertility concerns with their patients and really to have a very low threshold to refer to us for further discussion. I think, again, trying to, like, there a lot of the pushback from oncology teams tends to be like, oh, well, we didn't want to talk about it because we thought it might delay their treatment, or because we thought they were too sick, or because we thought like they probably won't want it, or they seem too overwhelmed is also sort of a common thing. Like, I just didn't want to add to what they were going through. Um, and while all this comes from, I think a really like genuine patient care like perspective, I also we have pushed back and said, like, we really need to have these consults and go over the risks and benefits and help people decide for themselves, and that includes even people who have medical risks that we know might preclude them. For example, I think neutropenia is a super common one. Like, somebody who has like no white cells is going to be a really like high risk surgical candidate, and and we discourage doing any procedures in that setting. But there's also a lot of data that says that people really often don't remember when they get the counseling from their oncology teams, and having this separate consult, even if we ultimately decide not to pursue fertility preservation procedure, this actually helps people to understand, like, okay, this is why we're not doing this. This is, if I hear somebody else is doing this with theirs, I don't feel like I didn't get offered something, or later I don't regret that we didn't have this discussion, and we can document that more clearly in the charts. Because unfortunately, another issue is documentation, that even if an oncology team is having this discussion, if it wasn't documented, it didn't happen, and it's often very hard sometimes to look through later and be the person diagnosing someone with POI and then look through the chart and see nothing documented about having a fertility conversation. And the patient is like, I don't remember this at all. And, it might have been that it didn't happen. It might have been that it happened and it just wasn't in there. But I think this can be really hard for people. I don't know if that answered your question. I think there's a
Yeah,
lot
it
that
did.
goes
Thank you
into that.
so much, Stephanie. And I really appreciate this. And I know there was a couple more questions, but I think we have to end our grand rounds. Thank you so much for joining us. And lots of accolades in the chat if you wanted to reach through it. And we really appreciate you sharing your expertise and experience.
Oh, I appreciate you having me. And if there's questions specifically for me, you can always email me or reach out. And you have a great team again at with your REI department and with Dr. Berger Chen from PAG. I mean, I think you have a lot of really like a robust system there already. So it was
Yeah.
very nice to be here. Thank you.
Thank you so much. Thanks, everyone.